Hello, everyone, and welcome back to our IPC podcast. My name is Jen, and here again with you for another edition. We are talking today about GRE, which is called Glycopeptide-Resistant Enterococci. It's another one in our little mini-series of Multi Drug Resistant Organisms. So I'm going to go over to you, Fran.
Yes. Hello, everyone. I'm Fran. I'm one the other infection prevention control nurse. Hopefully, we'll know that. You know our voices a little bit by now. So, yes, GRE or Glycopeptide-Resistant Enterococci. So, just as a starting point, it can also sometimes be called vancomycin-resistant enterococcus, or VRE, if you will.
Just because we love our acronyms and like
just,
to confuse people with lots of different names.
So, effectively what it is, so enterococci are bacteria that are frequently found in the bowel of many healthy individuals. There are lots of different species of enterococci, but only a few have the actual potential to be able to cause infections in humans. So they can cause a range of illnesses, including UTIs, urinary tract infections, bacteremias or bloodstream infections, and wound infections as well. So glycopeptide-resistant enterococci are effectively the enterococci that have become resistant to the glycopeptide class of antibiotics, for example, vancomycin and teicoplanin. So there are two very common species of GRE, which are E faecalis, and this is the most common type of enterococcus that you will find and causes around 90% of the infections. And then there's also E. faecium. I can't pronounce it.
Go for it, Fran. You got it.
Yeah, sure. Which they're seeing an increased frequency of in isolation of GRE.
Yeah, so thanks, Fran. When it sort of came about, like the emergence of GRE sort of came about in the 1980s, and the evidence is strongly suggestive of there being a direct correlation between the use of glycopeptide, the increased and heavy usage of glycopeptide antibiotics and the corresponding resistance to it. So we wanted to sort of have a chat about who is most at risk of acquiring a GRE. They mostly occur in hospital patients, but particularly in those groups within hospital who have a compromised immune system, or they've had previous treatment with certain other antibiotics, particularly the glycopeptides that we've already mentioned, and also other sort of families of antibiotics which are very, they're sort of culprits for causing GRE, such as cephalosporins.
Yeah.
We also know that there's a direct correlation between the length of a hospital stay and your corresponding risk of developing a GRE. Okay. And just one more.
Keep going.
If receiving care in any of our sort of specialist high care units, such as intensive care or critical care units and our renal departments. GRE are sometimes found in the faeces of people who've actually never been in hospital and haven't recently been given any antibiotics. We would sort of class them as just being colonised with it and it not necessarily causing them any issues whatsoever.
Yeah, just an add-on to that, actually, in terms of colonisation versus infection. In our last podcast we did on CPE, Jen gave a really, really good description of colonisation versus infection, so please revisit that if you are interested.
Yeah, essentially, it's just colonisation is the presence of something versus it making you sick and it causing an infection. Yeah. So that's so somebody can have this present within them and it might not necessarily cause them any issues versus them being systemically infected with it.
Yes, so that was a little roundup. So we're going on to talk about how it's acquired and the routes of transmission, effectively. So it's, acquired through, the main points we would find for a lot of infections, in that it can be transmitted by contaminated hands, environmentally through equipment and surfaces, and also remembering, as we said, because Enterococcus usually lives in the guts, that if a patient has diarrhea, then spores obviously can come out, land on surfaces, and that's how it can be acquired through the environment.
And so a paper I read just before this in preparation
5 minutes before.
cited that, when somebody has diarrhea, they can spread that little bit further and they can then land on surfaces and actually potentially survive up to a few days. So we're going to come on to it later, but we're going to talk about cleaning.
Of course we are. Why would we not?
So how we test for it, it would kind of depend on where we're looking. But if you were suspicious of somebody having an infection, we would then send a wound swab or a stool sample, a urine sample, or a blood culture. Those are the main areas in which we would find a GRE infection or colonization.
Absolutely. And again, next point, moving on to isolation. I think you love us when we tell you when we ask you to do it, if possible. So basically it would be to isolate the patient until advised by the infection control team whether it's necessary or not. Typically it is, and we would mostly recommend that you would. So we would then go on to say that either having a room with an ensuite or a dedicated commode if they have diarrhea, that's really important to try and maintain. And we know that a lot of side rooms don't actually have an ensuite, so it's just really trying to make sure that this patient has one commode and that is for their use only, and that it's also cleaned regularly whilst it's in the room as well. So it would be the main priority to isolate if they had diarrhea, if they had a drain in situ or a urinary catheter. So along the same lines for oncology and haematology patients as well, once they are GRE positive, you have to assume that they're positive for the whole of their admission. So they need to be isolated for the whole of their admission. And if they are readmitted, then we need to rescreen for GRE to see if they're still positive, but also making sure to isolate them pending their results.
PPE. What kind of PPE do we need for GRE? So it's our sort of standard PPE, but we need to, going back to what Fran said about the routes of transmission with GRE, we need to just make sure that we're using them carefully and appropriately. It's not like putting on a pair of gloves and suddenly you're invincible. You need to use them carefully. If you're going into a room with somebody with GRE, which we know is a Multi Drug Resistant Organism, you need to be wearing your apron, your gloves, and it's not just once they're on, you're done and you're sorted. You've got to change them in between tasks and ensure that you're using really strict hand hygiene, because you don't want to inadvertently carry that GRE on your hands to your next patient and risk making them incredibly sick.
Exactly, and also carrying on to what we do see a lot of, use of gloves outside on computers and the door phone handles, and it's just thinking about all those high touch point areas that we would hopefully normally think about. So really ensuring that we are doing that. And
segues beautifully into,
I was going to say, the moment that you have all been waiting for, of course, is cleaning. So the cleaning requirements for GRE. So red and green wipes can be in use, and we would always recommend cleaning the reusable equipment. So, your OBS machines, the the commodes, but also remembering to red clean a room on discharge and or transfer. So this is really important. So we're hoping at some point to be able to add some kind of prompt onto EPR, which should hopefully just give an extra little reminder. So that is something we're working on. Next point is no double dipping. So we would like to recommend using clean cloths for each task. Again, clean wipes for each task as well if you're wiping something down. Yeah,
that one, it's not just for our domestic colleagues.
Yes.
With the no double dipping, it's sort of like going back to our very first episode with Amy Cartwright from Gamma. It was, if you're looking at your wipe and actually you can see that it's visibly dirty, chuck it, get another one, get a clean one. And once you have cleaned it and then you look at your wipe and if it's still dirty, chuck it again and get a clean one. It's the same concept as double dipping. Otherwise you might end up recontaminating what you've just cleaned.
Yeah.
So be liberal, please.
Yes, just use as many as you want at the end of the day.
Sustainably, folks.
Sustainably. And then also just a little add-on for cleaning as well. So we've obviously got our new national standards of cleaning that are coming in gradually. You will have seen a couple of members of our team in domestics and a few other people doing some audits around, and we'll see a national colour coding coming in, ratings for the wards, star rating at the end of June, I believe it was, or sometime in summer. So that's something to keep an eye on, and then hopefully it's something we can all look at to improve if needed and see where we're potentially going wrong.
Yeah, I really like and celebrate where we're going right.
Yes, exactly.
I really like the new national colour coding scheme, mostly because I'm a geek, but secondly, it's just a really easy visual way for knowing that you're using the right colour cloth, like for instance, red cloths on sanitary items, 100%. Just to know that we're not accidentally contaminating other areas.
Yeah. Definitely.
So the next point is one that we brought up on the CPE talk, and I think it's a really important one. I think it's one that we will try to bring up on all sort of future topics, because it's something that we have to consider. Is, are we safe as staff members spending lots of time with patients with multi-drug resistant organisms? And the answer is the same as with CPE. Yes, you are. If you have any concerns, if you have any long-term medical conditions, then by all means, make sure to speak to your line manager if you have any concerns. But essentially the answer is yes. Use your PPE, wash your hands, and you will be A-okay.
It's all going to be all right. And again, similarly to our CPE episode, visitors is a question that we get a lot as well. Are visitors going to be safe? So it's typically not a problem for healthy people, but obviously we would recommend our usual, which is wash your hands before and after contact. If your visitors can be encouraged to do that, then that would be absolutely brilliant. And also I was going to add actually just a little addenda, as it were, also considering things like your PVC care, your peripheral venous catheter care, or just checking, and wound care as well, just making sure it is documented, making sure that there are dates on there, because VRE can end up in your blood as well, as we have said previously, and one of the easiest ways for it to do that is via cannulas and catheters and whatever else really. So we would really, really encourage using that tool on EPR for documentation of that, so everyone can see when it was put in. Is it clean? Was it put in aseptically? All of that really, and that will really help with preventing this infection from having a wider spread around our units.
Yeah, because we have seen a bit of an increase in GREs within the trust over the last few weeks.
Yeah.
So we are just at the very beginning stages of looking into it, seeing what we can do, what information we can find out that is sort of pertinent to this. And we're looking at getting some assistance from our antimicrobial pharmacists, potentially over the use of vancomycin, and whether or not that's something we might have been a bit heavy-handed with of late. But obviously it is also an important antibiotic that we use in our arsenal for treating C. diff. So we are looking into this currently, and any updates, then obviously we will let you guys know. But the sort of take-home messages are any concerns over your patients, whether or not they've got a mucky-looking wound, PVC, whatever. Get those samples sent to the lab. We can't do anything until we know what we're working with, and just please keep your hand hygiene really strict. Use your gloves appropriately. And clean. But I feel like it's come at actually a good time, us recording this podcast with, as Jen said, the emergence of more VRE case or GRE cases. So if you have any, it was entirely on purpose, of course.
Entirely on purpose. So if you have any colleagues that are worried about it, they're worried about GRE, and they just want to know a bit about it, and they want an easy way to access it, hopefully this podcast is easily accessible. And if you could just pass on the details to them, or just anyone that's interested in general, really.
Give us a call or reach out to microbiology colleagues. But please reach out, and we will look forward to bringing you future topics on MDROs.
Yeah. Yeah, as usual, any feedback, good, bad,
Please.
is very much appreciated. We are looking to do a little bit of research into the use of podcasts and how they are beneficial, hopefully, for educational purposes. So we would really, really appreciate any feedback whatsoever. It doesn't have to be really long, just 2 words would be great. So yeah, we would really appreciate that in any manner. And then obviously, as we always say at the very end, if you need to contact us, we're extension 6122 for Gloucester and extension 3129 for Cheltenham, or we've got the acute ICN email address, which can be found in the address book. So yeah.
Thanks very much, everyone.
Thank you guys. See you next time.
Bye.
Bye.